Ian is the blood transfusion manager from the Royal Cornwall Hospital, and he will be talking patients with anti-D.
Thank you, Carol. Slightly different format to this session. So this is more of an interactive poll for people to get involved in. So we're just going to go through some questions, and some options will appear on the screen, and you should be able to click on them, and then we can talk around each one. So first one, which antibodies are more clinically significant, IgG or IgM? The second question was, what temperatures generally do IgG antibodies work at optimally? 4 degrees, 22 to 25, 37 or 45. Next question is, can IgM antibodies cross to the placenta? Simple yes or no answer. Question 4, are ABO antibodies IgG, IgM or both? Next one, ABO hemolytic disease of the fetus and newborn is worse in which maternal blood group? A, B, AB or O? Can't see the questions. Yeah, so if you think those who can't see the questions, we'll get the polls up at the end, and then I can read them out again, and we can stick them in the chat, and we can talk about them a bit more then, if that's all right. Are A and B antigens fully developed at birth? Yes or no? Are all other antigens, red cell antigens, present on the fetus at birth? Yes, no. Anti-Kel, so large K, suppresses erythropoiesis rather than removing or hemolyzing fetal red cells. True or false? Maternal phenotyping is an important part of management where anti-Kel is detected. True or false? Are titers a reliable way of assessing the severity of hemolytic disease of the fetus and newborn due to anti-Kel? So your titers 1 and 2, 1 and 4, 1 and 8. Is that yes or no? Next one, which of the following concentrations for anti-D in international units per mil is classed as high risk for hemolytic disease of the newborn? Greater than 15, greater than 4, greater than 7.5, or to be honest, I don't know. At what concentrations do prophylactic anti-D reach? This is international units per mil. 0, 0.2, greater than 4, greater than 10, or to be honest, I don't know. Just a few left. Which of the following concentrations for anti-little c is classed as high risk for hemolytic disease of newborn? Greater than 4, greater than 15, greater than 20, or again, I don't know. Question 14. When immune anti-D is detected during pregnancy, how often should the patient have samples referred for testing? Booking bloods, 28 weeks, 34 weeks, every 4 weeks until 28 weeks, and then every 2 weeks, or only when the level is greater than 4 units per mil. Which antibodies are quantified in units per mil instead of titered? FYA, B, so Duffy A, Duffy B, little c, K, sorry, Kel, D, big E. From what gestation is Kleihauer needed to assess potential fetal bleed? So as soon as from booking bloods, from 20 weeks, any sensitizing event regardless of gestation, or the third trimester only. 3 left. An RHD positive pregnant patient attends A&E with abdo trauma and PV bleeding. Should a Kleihauer test be performed? The RHD positive patient, yes or no? Do all hospitals in the UK have the same size dose of prophylactic anti-D? Yes or no? An RHD negative patient, 29 weeks pregnant now. She had prophylactic anti-D last week at 28 weeks. Now is coming at 29 with a PV bleed. Does she need another dose, even though she just had one last week? Yes or no? And finally, which combination of antibodies does anti-G look like? Big C and D, or little c and little e, or D and big E, or I don't know. And then we've got those who can see the poll. It's worked for me. I can now see the submit button. So we click on that. First question, which antibodies are more clinically significant? 57% went for IgG and 9% went for IgM and 34% went for both. It's the main answer is IgG. That's one we're more interested in because IgG antibodies work at 37 degrees, whereas IgM ones tend to work slightly cooler at 4 to 25 degrees. And obviously your body temperature is 37 degrees, therefore they're more likely to react then. Excellent. The second one, what temperatures do IgG antibodies work optimally at? 94% went 37 degrees. Yes. So the vast majority do work at 37 degrees. Yes, some can work slightly cooler, but for simple transfusion science, 37 degrees. Can IgM antibodies cross the placenta? 15% said yes, and 85% said no. IgM antibodies generally cannot cross the placenta. It was thought that the placenta is just like a simple sieve. So the smaller molecules, the IgG, can get across, whereas the IgM, which is a 5, it's a pentamer, cannot cross it. However, it's now known that the cells of the placenta carry receptors for the Fc piece of IgG molecules, and so there's an active transport system for getting IgG antibodies across the placenta. Are ABO antibodies IgG, IgM, or both? Excellent. 59% went for both, 32% IgM, and 9% went for IgG. Anti-A and anti-B are most often a mixture of IgG and IgM. ABO, hemolytic disease of the fetus and newborn, is worse in which maternal group? A, B, AB, or O? Excellent again. 59% went for group O, 24% went for AB, 6% B, and 12% A. Group O mothers tend to produce large amounts of IgG, anti-A, anti-B, and anti-A, B. And generally, anti-A, B is more often IgG. Those in group O have worse hemolytic disease. Oh, 50-50. Are A and B antigens fully developed at birth? Yes, 45%. No, 55%. No, they're not. Generally, they're not always developed at birth, even at full term, 40 weeks gestation. Sometimes they can take several months to become fully developed. So generally, ABO hemolytic disease of the newborn is not as severe as perhaps some of the other antigen-antibody incompatibilities. Are all other antigens present on the fetus at birth? Yes, 18%, no, 82%. So again, correct. Yep. So it does take a while for some of the antigens to fully develop. So the mum can have a really high antibody level, but if the antigen is not fully developed on the baby, the severity will not be as worse. Anti-Cal suppresses erythropoiesis rather than removing hemolyzing fetal red cells. True, 73%, false, 27%. Yep, it does suppress erythropoiesis rather than destroys them. And if you come across a case due to anti-Cal, it's very important to remind the clinicians, midwives, obstetricians to follow the baby up for several months, weeks and months after delivery, because anemia may be profound at birth, or in fact, it could take up to 2 months to develop. Yes, paternal phenotyping is an important part of management where anti-Cal is detected. True, 82%, false, 18%. It's also important in any antibodies. If the mum's got any antibodies, we always recommend to get the father tested as well to see what if they have the corresponding antigen. Are titers a reliable way of assessing the severity of hemolytic disease in newborn due to anti-Cal? Pretty much in the middle. Yes, 53%. No, 47%. No, it's not. No, there's no correlation with the titer and severity. So you could have one patient who's got really high titer and the disease could not be as bad. Another one could have a very low titer and it could be very severe. Yeah, mixed field here. Which of the following concentrations for anti-D in IU per mil is high risk for hemolytic disease of newborn? Greater than 15, 24%, greater than 4, 27%, greater than 7.5, 15%, don't know, 33%. Generally, don't worry, because whenever you send samples off to NHSBT RCI, their reports will come back. If you haven't seen them, they will put clinical comments on there signed off by their consultants, advising whether it's high, medium, or mild risk of that. At what concentrations does prophylactic anti-D reach? 0%, 0.2 IU per mil, 41%, 18% said greater than 4, 6% said greater than 10, and 35% weren't sure. Generally, it's about 0.2. If you give a patient prophylactic anti-D, even several doses of perhaps a higher 1500 IU injection, the levels generally don't increase beyond 0.2 IU per mil. And that's the only way we can really differentiate between prophylactic anti-D and immune anti-D. Sending the samples off to RCI labs, they can quantify them. And if it's coming out about 0.2, 0.1, 0.2, suggestive prophylactic anti-D. If it's come back at 4 or 5 IU per mil, it's going to be immune anti-D. Which of the following concentrations for anti-littoral C is high risk for hemolytic disease of the newborn? Greater than 4, 15%, greater than 15, 21%, greater than 20, 18%, and don't know, 47%. So same as anti-D1, RCI reports are very, very helpful, and they'll guide you and the clinicians. They'll put the comments on there, so don't worry too much about that one. So when immune anti-D is detected during pregnancy, how often should you have samples referred? So booking, 28 weeks, 34 weeks, which is sort of a standard appointments a pregnant patient will have. 12% said that. 88% went for every 4 weeks to 28 weeks, and then every 2 weeks up until delivery. And brilliantly, no one said only when the level is greater than 4 units per mil. And that's from the BSH guidelines. If you're not sure about anything, not just what we're talking about today, but look at the guidelines. You've got guidelines on pre-transfusion compatibility, transfusion reactions, screening and pregnancy. Which antibodies are quantified instead of tethered? So about a quarter went for Duffy A and B. Little c, RH little c went for 12%, Care was 26%, 35% went for D, and 3 handful went for big E. It's only little RH, little c, and D are quantified in IU per mil. All the others are tethered, and very few labs can actually quantify C and D, so we tend to send them straight off to RCI labs. From what gestation is a Kleihauer needed to assess potential fetal bleed? From booking bloods, 0%, excellent. From 20 weeks, 56%. Any sensitizing event regardless of gestation, 38%, and the third trimester only 6%. It's from 20 weeks. And again, if you're not sure, go back to the BSH guidelines on testing in pregnancy. Question 17, an RHD positive pregnant patient attends A&E with abdominal trauma and PV bleeding. Should a Kleihauer test be performed? So 50-50 here, 53% went for yes and 47% went for no. Generally, we do not do Kleihauers on positive patients unless they're querying an abruption, a fetal blood loss. And that's something you need to be aware of. You may get asked to do a Kleihauer on an RHD positive patient, not to see if the mum needs prophylactic D, but purely to see how much blood the fetus has lost, so they can manage the fetus. Do all hospitals in the UK have the same size dose of prophylactic anti-D? 29% said yes, 71% went no. The answer is no. There's different doses, different sizes available across the UK, and it's something you really have to be aware of, especially if a lot of hospitals move around during the holiday seasons. Some will have the larger dose of 1500 IU, and they'll have a one-dose strategy at 28 weeks. Some will do the smaller doses of 500 IU at 28 and 34 weeks. So if your hospital is on the single 1500 IU dose and you go at 28 weeks, but a patient's come down to visit and they've only had a smaller dose at 28 weeks, 500 units, they will ask for a second one. An RHD negative patient, 29 weeks pregnant, had prophylactic anti-D at 28 weeks, now has a PV bleed at 29. Does she need another dose a few days later? 85% said yes, and 15% said no. Excellent. Always have the prophylactic anti-D at 28 and 34 weeks. They must have that regardless of if they've had trauma, PV bleeding, even the day before, same day. Always given the 28-week dose, and the trauma needs separate doses. And the final one, which combination of antibodies does anti-G look like? C and D, 44%. No one said little c, little e, which is good. D and big E, 6%, and don't know, 50%. So it's quite interesting. Generally, we're not told much about anti-G in the start of our careers in transfusion. It is very important in pregnancy, management of pregnant women. The correct answer is looks C and D. And I strongly recommend you go off and read about that, because if it's anti-G, the mum could still make anti-D, therefore she must have prophylactic anti-D. Whereas if it's actually anti-D, she does not need anti-D injections. So go on and have a look at it. But generally, RCI labs will pick it up for you. But it's very interesting reading about the number of D antigens on the R2, R2 cells, the G antigens on R1, R cells. Have a look at it. It's very important.
We've got a question in the chat, which is, what is the difference between quantification and titration?
Yeah, good question. Quantification, they're measuring it, the sort of the concentration in IU per mil, which they're only doing for D and little c. The titers, you're basically diluting it out, so in serial dilutions, just to see what the endpoint is. Why all antibodies are not done or quantified, to be honest, I do not know, and I think it's purely driven by cost here, because ideally we could quantify all antibodies, including the big E's, JKAs. But unless somebody else knows the answer to that one, I think I need to go off and do some further reading.
I think it's due to an international standard, having a validated international
of course it is.
standard.
You've got the
Sorry.
Standards, yes. There you go. Yeah, you've got the anti-D and anti-C standards from the National Institute of Biological Standards, so they can compare to that.
And another great question, why is anti-K not good at assessing the severity of HDFN?
Yes, it doesn't correlate with the actual titer, because it suppresses red cell production, erythropoiesis, rather than hemolyzing them. And so why anti-K is not assessing severity? It just works differently than the other antibodies, because the other antibodies, as the titer goes up, there's more of them. It's a simple antigen antibody interaction, and it will just destroy the red cells. Whereas anti-K will cross in there and affect the baby's stimulation of red cells. And it just varies from individual to individual. So it's not really, I think I've really answered the question there. It's a very tricky one. And I would probably have to refer that to a fetal medicine consultant for that one.
Working in the transfusion lab, I think we all realise that anti-K does exactly whatever it wants as well, rather than react how you think it should react, in terms of not always being able to see an enzyme. So yeah, it is a really tricky one. Oh, Vikki.
Hiya, just a comment really. I was really pleased to see your Kleihauer question about doing a Kleihauer on a rhesus pos or RHD positive patient, because I had this question myself in some training with midwives yesterday, and they're like, why would you do a Kleihauer if the patient's not RHD negative? And I think it's really important to separate that a Kleihauer is a separate test. And the reason for that test is assessing fetal maternal hemorrhage, which then allows us to calculate the dose of anti-D required for that hemorrhage. But the Kleihauer just assesses a hemorrhage, so it is a separate to, doesn't necessarily have to go with RHD negative and anti-D use. So it's really good to see.
Yeah, I think in the RCOG guidelines as well, for late intrauterine death, the Kleihauer is recommended, so that's in the obstetric guidelines. Yeah, so we're on for a 10-minute break now, so well, if we can see everyone back by 11.